the American Society for Quality. And you are joining us today. Good morning, good afternoon, or good evening, depending on where you're calling or joining us from. Today's presentation is called Government Reduces Barriers and Takes Quality Improvement to Scale Across All Counties in Tennessee. And we're joined today by Micky Roberts, who I will do a more thorough introduction in a few moments. So if you can advance to the next slide, Neota, I appreciate it. So again, we are bringing you this webinar by the American Society for Quality, ASQ, and the ASQ Government Division. And again, I'm the chairman of the Government Division. My name is Mark Burson. And we're being supported by Neota Brown today, who is our technical lead, as well as Catherine at headquarters. So I really appreciate the help both of you have been. It's been tremendous. So you can move on to the next slide, please. So ASQ represents the voice of quality throughout the world with over 80,000 members. The Government Division is one out of 26 divisions in the society, and the Government Division is a community of practitioners focused on quality and performance improvement for federal, state, local, and international governments. We are composed of government leaders and employees, seasoned experts, consultants, practitioners, university professors, students, and others engaged with or interested in the public sector. So we certainly hope that you consider joining our community at some point. And we do announce, first of all, we do webinars. We've been conducting webinars typically once a month, and we will be announcing webinars. Well, we do that all the time. We announce new webinars coming up. There will be another one coming up in April. And we just stay tuned because we'll be announcing those as well as the dates and the specific information on the presenter. And so just stay tuned, and that'll come up soon. For today's webinar, use the Q&A tab below if you have any questions. At the end of the presentation, after Micky speaks, we will have a Q&A session, and I will address he will address as many questions as possible at the conclusion in the last about 10 minutes or so of the presentation. We also have a listing at the end of the presentation of contact information for the division officers as well as Micky. So feel free to reach out to any of us if you have additional questions. Most presentations are available for download within a few days of the webinar. I believe we are recording this one today, so if we are, then there will be a recording available as well. So now I have the great pleasure of introducing our speaker today, Micky Roberts. But let me say a few words about Micky. Micky Roberts is a former director of the Office of Performance Management with the Tennessee Department of Health. He has been a national and state level Baldrige examiner, as well as lean facilitator and trainer. Additionally, he is a graduate of the Disney Institute in Service Quality. He directed all quality improvement efforts, including utilization of the Baldrige framework and collaboration with the Tennessee Center for Performance Excellence. Micky has publications in peer-reviewed journals in both public health and quality fields of discipline. He has worked for county, regional, and state public health in Georgia and Tennessee for 30 years. Micky has been a guest presenter and hosted workshops on both the national and international stage concerning public health and performance excellence. So, without further ado, I'd like to turn the presentation over to Micky Roberts. Thank you.
Thank you, Mark. First of all, I want to say thank you for that kind introduction, and thank you to Nyota and Catherine and the ASQ division for government division for the opportunity to share the TDH story, taking quality improvement to QI to scale across all counties, all 95 counties in the state of Tennessee. I must make also a disclosure statement that as a retiree, I no longer work for, nor am I an official representative or spokesperson for the Tennessee Department of Health, or TDH. Furthermore, most of the content you will see here today is available on the TDH website at tn.gov/health, which is at the end of the slide deck with other resources. So basically, I'm sharing my experience from working there during this time frame. So the next slide describes the webinar topics. And so we'll be looking at one of the anchors that were implemented, were put in place to secure this operational excellence program across the state of Tennessee, state government, all state government departments in Tennessee. Then, of course, what are those barriers? What did we encounter that help impede public sector operational excellence programs? And then third, how important was entrepreneurial thinking in establishing successful operation excellence programs? So in the next slide, you should see a title, The TDH Way, Accelerating Excellence through Performance Excellence, Moving Beyond Compliance, which we are well versed in government, to innovation and improvement across the enterprise. So over the past 8 years, we discovered that performance improvement and pursuit of excellence is possible across a large state governmental enterprise, and it can have a dramatic and positive impact on both the workforce and the public that we serve. At the end of this 8-year period, the culture change resulted in a shift away from a predominantly compliance-based service mentality or a grant spin-down mentality. It's one focused on customers and making services more efficient based on work process innovations. As a result, the Tennessee Department of Health received 3 national recognition awards from the Association of the State of Territorial and Health Officials. This is their highest award from ASTO. It's called the Vision Awards. And we won those for 3 consecutive years, which was unprecedented. This first effort of quality improvement going to scale in 2015 was the first award, which we're talking about today. The next year, our Safe Sleep Hospital project to address SIDS, Sudden Infant Death Syndrome, which used a lot of these principles we're talking about today as well, because this was the peak of our work during this time period. And then 2017, Tennessee Tobacco Settlement Program, which was $15 million appropriated to the Tennessee Department of Health over 3 years, that we seized that opportunity to use that as a performance learning lab to diffuse to all the counties. So on the next slide, titled The TDH Way, Innovate to Accelerate, like a good Shakespearean play, I'm giving you the end of the story in the first act. So we called this effort to take QI to scale the TDH Way, Accelerating Excellence, or Innovate to Accelerate. Through the Office of Performance Management, the Tennessee Department of Health applied performance improvement and excellence tools and techniques such as Lean, Six Sigma, and Baldry's principles from the framework to establish a systematic, innovative process that could help Tennessee become a healthier state. Once counties became proficient in the use of the tools in the innovation toolkit, the results could be recognized and demonstrated for the examiners from the state's Baldrige Alliance program or the Tennessee Center for Performance Excellence. So next, the level of achievement awarded, or the map on the left, you can see that designated and color-coded for the counties that used the Baldrige framework and applied their learning. So the first group awarded level 1, recognized in gray, thus receiving their first third-party industry validation. feedback, and recognition. So this encouraged them to go beyond lean principles training and to advance to facilitator level training that we provided. So they could use a wider variety of tools to identify root causes, reduce variation, or eliminate waste depending upon their data. So consequently, the more that these tools were used and documented by counties, offices, divisions, and units, they could reach for higher levels of achievement using the Baldrige framework, such as levels 2 or 3 for the blue and red color counties on the map on the left. This feedback loop represents the Innovate to Accelerate cycle. However, this is actually near the end of our story, so one may ask, how did we get here? What were our barriers? So next slide, you'll see how we anchored down performance excellence and grew it across the state enterprise, impacting every county in the state. So we were fortunate in that leadership was already on board. Our new commissioner for public health at the time, Dr. John Dreisner, is a proponent of Baldrige, and so was behind the idea of leveraging the 7 focus areas in performance excellence from the Baldrige framework. So we took an integrated approach. It was actually multi-phasic over 8 years and included the following sequence. First, the new senior leadership came in and looked at the organizational chart and revamped it, creating a new deputy commissioner position for continuous quality improvement and training. A new strategic planning process was put in place by the executive leadership team, which included frontline employees using a SWOT analysis. This was the first time that was initiated at that level and was made available for all employees to participate in via Survey Gizmo. This was the first time that the executive leadership team defined our core competencies. Second, they identified who were the early innovators and the early adopters that could create a focused team or hub for performance excellence. In other words, creating the new Office of Performance Management. It was important to them that this team be developed and evolved amongst the rank and file, and not hiring a third party or a different group to come in who could create this entity and perhaps be seen as outsiders. So this was a voluntary approach. The team received additional training and became champions for utilizing Lean Six Sigma tools, as well as receiving Baldrige Examiner training, and were some of the first level 1 achievers with the state Baldrige Alliance program or the Tennessee Center for Performance Excellence. So third, sharing of the tools. This initial rollout of Lean principles was taken to scale. It went to every county health department, and there's a county health department in every county, to give everyone a baseline understanding of Lean. Every employee was required to go through the modules. This was the only time that the introductory modules were required for every employee in the state of Tennessee. After that, they were all voluntary. So it was a multi-pronged approach. It wasn't simply the organizational chart of creating new structure as a platform to begin talking about performance excellence. There was also the other prong was modifying the employee's evaluation. And so we embedded risk-taking and innovation into the performance evaluation process, and we linked it to the reward system, pay for performance. So the TDH leadership ensured a maturing systematic cultural change strategy across the enterprise year after year. So it's not only structure and a platform, it's changing what typically government employees listen to, and that's their performance plan and their performance evaluation. You'll notice the next dot, the fifth dot there, that it is a dot. It is not an anchor, and that's because initially this opportunity that came to us through the state legislature and the Master Settlement Agreement for Tobacco was not anticipated. It came in year 2014, but we saw as an opportunity that we could leverage. So we seized that opportunity, and we decided, instead of just rolling out a grant program like we do so many times, that let's take the opportunity to develop a state learning lab for performance improvement. As I said, this was in 2014 with funding appropriated from the state legislators and the Tobacco Prevention Master Settlement Agreement with states and tobacco companies. So this accelerated the use of PDCA and ADLI concepts, and as a result, counties were provided funding outside of the compliance-based grant spend-down mentality to a semi-annual PDCA reporting process that built upon learning, innovation, and return on investment as measures of success. And we'll say more about that later and how it became an anchor over time. The last anchor was to continuously reward and recognize and challenge employees in this effort and staff. So for the first year rollout, new adopters volunteered and were trained and or became applicants in the Baldrige application process. Adopted performance management identified and shared best practices, including what didn't work. In year 2015, we launched a new rapid improvement event, annual challenge, and identified greatest improvements. Participants could log in and load in loadable forms that they could upload of many Lean Six Sigma tool usage. These were templates that we designed on 9 different tools that our staff could easily use. So the next step, you'll see the traditional bell curve, barriers to implementing performance excellence across state government enterprise. And so, of course, we're seeking those 2.5% of innovators, the first takers, those who are willing to launch into a new idea that we have not done before in this particular Department of State government. So when we were putting this together, we decided to take a diffusion of the innovation approach in deploying performance improvement to grow ownership. So in order to address these barriers concerning implementation of performance excellence, we did utilize this diffusion of innovation approach in an attempt to dispel myths and anticipate erroneous perceptions based upon group meetings and survey gizmo questionnaire responses. So according to Everett Rogers in his work in social science on behavioral change modeling, where this diffusion of innovation model comes from, there are a series of stages that one goes through before deciding if they're going to adopt, adapt, or reject an innovation. Furthermore, there were staff perceptions that fueled these barriers. The questions had to be resolved to move forward. For the next slide, you'll see a short bullet list of a few of the barriers that we knew we had to address. The first one was relative advantage. Is this effort worth it? Is the juice worth the squeeze, so to speak, for me to spend time participating in this? I was originally one of the naysayers. When this was first presented to us, I thought it was another audit program. And at the county level, we are already audited by the feds, by the state, and by the county. And the last thing I wanted was another audit. So I didn't think this was worth it at all. Second is compatibility. Will it fit government, public health, and primary prevention coming from the corporate world? Next was complexity. How steep is the learning curve? Usability. Can it be adapted, experimented, or tested with? Cost. How much will this startup cost? How much local dollars do you have to put into this to be able to make this work? The exposure level. What happens if we identify processes that are under my nose that are broken and aren't working? Will I be embarrassed by the information that we discover? Ownership. Who owns the work? Can I use this work with my local communities, and can they own it? So on the next slide, you'll see how we address these barriers to implement the systematic performance excellence program across the state. And as usual, I have to tip my hat to leadership and our commissioner. The commissioner at that time was Dr. John Dreisner, as I said earlier, and he made an appeal and brought our state's first county metro Baldrige champion, the only one in the state to achieve the level 3, the only one in the state working with Baldrige at that time, to a statewide retreat with all the other county health directors. Initially, there were no risk takers due to these questions that still remain. And the director there, his name is Gary Self. It was Sullivan County. And Gary made it clear that this would be a win-win adventure, and it would help reduce your costs in what are called relative value units per service event. These are numerical output measures of clinical efficiency and effectiveness that every county health director knows and that every county health director has in their individual performance plan. So the local health department is the nexus for customer engagement, and the primary metric in every county director's IPP are these RVUs, or relative value units. And it is part of the resource-based relative value scale used in the United States for Medicare in their reimbursement formula. So once he shared that information that it could increase our efficiency, it piqued staff interest. And so compatibility, alignment with public health evidence base, so potential adopters can adapt the innovations from the toolbox to meet specific county needs. Jerry made it clear he could do that for Sullivan County. Complexity, there's a commitment by the central office that all trainings, all expenses for any staff wanted to be trained in the Lean Six Sigma tools or in Baldrige. It was all paid for by the central office through my division, which is the Office of Performance Management at the time. And we had a hefty budget to be able to handle that for all the employees as it increased over time. Is it usable? The extent to which the innovation can be tested. Initially, no, in the first year, because we had so few innovators. But within the second year, we developed an advisory group who were from the peers who volunteered, the innovators, and they helped support with the early and late adopters that followed. Costs, I've already talked about all the costs out of pocket were covered, and the return on investment would finally come for each participant because the individual performance plans would now include risk-taking and innovation. So theoretically, you could score higher on your performance plan and receive a higher raise if you participate in risk-taking and innovation. So opening up a can of worms, the examiners are third-party industry reviewers, and they signed a confidentiality oath. So you only release the information that you wanted to. Of course, we encourage transparency and safety, trying to encourage everyone to share all your learnings, and no one needs to worry about being cast in a bad light or an embarrassing situation. But it was up to you what you wanted to share. Ownership, staff share the stories. We developed a SharePoint platform that all employees could share the information that they wanted to and look at best practices and problem solve. So after all that, to make a long story short, 7 volunteers emerged. These volunteers represented our innovators. So the next slide should be looking at entrepreneurial thinking. And so for this particular presentation, I thought it was important to use an analogy, and the analogy is looking at a forest, which is composed of trees representing different offices, divisions, and departments of state government, or traditionally seen as silos. So moving people to systems thinking, to looking at all the trees and how those trees can be integrated instead of being in our standalone silos. So how do we integrate innovation? We sent teams from all state departments to the Lean training classes to attend. So these folks developed a rapport. These students began to engage with each other and study together. So we had islands of innovators nested in each of the state departments that could communicate with each other. Fluid ownership, shared knowledge across departments through the SharePoint platform that I mentioned earlier, where different state departments could share their best practices. So tips, which you may have heard, keep it simple. We're going to call it silly. That's not as derogatory. We used limited modules initially, only 9 tools that we trained on, and made easy-to-use uploading templates so that participants could upload their results to us in the Office of Performance Management and SharePoint. Make it easy to win and hard to fail. After all, it is a national forest, in our context, a government forest. So now we're trying to change the culture to realize that a failure becomes a win because it is identified as a missed opportunity. It's something that we can work on. After working for state government 30 years, one realizes that processes may not allow for nimble or agile modifications. But we learned that if we could change, adapt, and modify some processes within systems, we could begin to steer the ship, especially when the rudder is HR. And having HR involved was one of the prongs of this multi-pronged approach that really made a difference. Spotting opportunities. Tree species, they don't stay in one place. Succession happens. Other trees come in, other plant community species replace another. Similarly, we learned that the work processes, especially concerning innovation, needed to come online, making previous processes perhaps no longer even necessary. We were able to showcase examples of this concept in the Tobacco Prevention Learning Lab, and we'll talk more about that. Suspending assumptions about what others do or do not do in their jobs. We use Gemba to listen to the frontline employees, to develop STAR teams and advisory groups. So we could dispel myths about both leadership and management, the leaves and stems, if you will, those folks in the corner office, and the frontline employees, the roots, if you will. Communications had to go in both directions, up and down for the tree to survive. 7, the next one, take risks. Lightning and fires happen, opening new patches for growth. So we gave permission to fail and encourage risk-taking codified into individual performance plans, shifting the culture from a gotcha to a nice catch mentality. So for us, our main context of entrepreneurial thinking was seeing the whole forest as integrated and connected instead of just one tree, because no department, no office, no division is an island. So if we go to the next slide, I'll actually make this one very brief, because this slide is a drill down to the previous slide, number 10, or the basic principles we use to anchor. So you can read the points in red and expound upon each anchor, our value of leadership leading with humility, introducing the SWOT analysis to frontline employees. We had 3,000 inputs from frontline employees in the first year on the executive leadership team strategic planning products, the mission, vision, and values. So this wasn't just a top-down approach. The Office of Performance Management, instead of just teaching lean principles, we taught facilitation so we could get the multiplier effect and accelerate the diffusion of these tools. We use Baldrige for enterprise alignment. I already spoke to the reporting templates to make easy uploads for reporting and sharing. SMART goals came online, coaching, a new process triad between the managers, supervisors, and employees, up and down the line in communication, and recognizing that innovation and risk are now linked into pay for performance. Diffusion of innovation. What helped us there was not only to identify some innovators, but the early adopters, because the early adopters are seen as experts. They have clout, they have the ear of their fellow employees, so they could persuade more so than the innovators, who may be superstars who are chasing after the next thing. But the early adopters were the ones that could really help us reach the tipping point. And for us, that's 16% of the population you're working with. So for us, if we could get to 15 units or counties, that was our tipping point where the effort would gain momentum by itself. So growth and learning opportunities emphasized. We track the tools and the use of the tools. The most popular, which may be no surprise, are the 5 whys, value stream and process mapping, PDCA or SA, easy uploads. Reward and innovation starts in the beginning. folks who are engaged in individual performance plans and the performance outcomes and using these tools. We even changed the definition of customer to include frontline county employees as customers of the regional office and the central office in Nashville. So folks who worked in regional office and central office, they were also evaluated on how well their customer service was to the county or frontline employees. So the next slide is the state of Tennessee, who is TDH. Tennessee Department of Health was established in 1923. It's one of 23 cabinet-level state government departments in Tennessee. In our executive branch, reporting to the governor, our mission is to protect, promote, and improve the health and prosperity of the people in Tennessee. You can see the rest of the details, the information on that slide. Suffice it to say that we have a presence in every county in Tennessee, and we have a high-level view of what the Tennessee Department of Health does in the next slide. So the next slide should be, what does CDH do? Well, basically, we see 1.7 million people on average per year, or 1 out of every 5 Tennesseans in our direct clinic-based service facilities. Now, these are just an example of the direct services that we provide in clinics. This does not include the indirect services, such as restaurant inspectors, health facilities inspections, birth and death certificate, vital records, that kind of indirect service as well. So the next slide, Alders provide a common platform to bring about alignment concerning systems thinking. This is just one example. If we look at if this is a clock and you look at the 10 o'clock hour, managing for innovation. So we knew that one of our core values and concepts was innovation. So how do we embed this in systematic processes? How are we going to operationalize innovation? Who's going to lead it? How does it engage the workforce? Where does it fit in our strategy? And then from there, what are the performance yields? What are the results for that particular value or concept? So many of you have seen this, the Baldrige chlorine hockey puck. A while back, it was a hamburger. So these are just the 6 processes in the 7 results category that we used to introduce this to staff. This is another way that they owned it and introduced it. One of our entrepreneurial ideas was to keep it simple, silly. So in that entrepreneurial spirit, staff came up with their own image. They said it was the plastic thingy that holds the 6-pack together, and the cans of the 6-pack are innovation tools. So I actually thought that was quite clever the more I thought about it. So process 1 leadership, management, people, and processes. So suffice it to say that everyone in public health knows the 3 core functions of public health: assessment, assurance, policy development, and the 10 essential services. So the first charge that we gave management leadership was to take all these essential services, all your work processes, and put them into 3 categories. So and those 3 categories are systems that do the work, guide the work, support the work. The categories, the work processes are on the next slide, but this visual representation is one that was easily used with staff. So the wheel on the right changes the color code to those services in line with those 3 particular categories. So on the next slide, the next slide, process 1 leadership is simply those 3 categories, the systems that guide, like leadership, governance, performance, innovation, planning, systems that work, community-based clinics where the work takes place, systems that support, HR, finance, supply, et cetera. So that was the first rubric that was used in getting management to think about their processes, work processes, and how we could categorize those. So the next is strategic planning. I've already talked about how that process was changed. And our challenge in primary prevention is measuring outcomes because it's basically we're measuring what doesn't happen, the people that don't get sick, the people who disease is prevented from. So public health is about moving upstream in primary prevention. In other words, addressing the causes of morbidity and mortality. In other words, what are the things that make us sick and what are the things that kill us? And so for Tennessee, that's tobacco, obesity, physical inactivity, and substance abuse. And this is where the fifth anchor emerged with the tobacco prevention opportunity that came up. So if you go to the next slide, which should be titled Primary Prevention, Contributing Factors of Behaviors that Contribute, moving upstream, as public health is good at, trying to get at the root causes. What are the root causes of nicotine and tobacco addiction? It's starting young, initiating smoking behaviors young, being exposed to secondhand smoke, and growing up in a family or being with familials that smoke. So the health department is about getting to people before risky behaviors start and not waiting for people to become sick, which is secondary or tertiary prevention. So how did we do this with the $15 million that was given us by the legislature over the past 3 years? So we took an evidence-based approach and decided to use these funds in a Performance Excellence Learning Lab. So in this slide, you'll see how the county is engaged in an assessment. They submitted annual plans, which included 2 semi-annual PDCA reports. You can see how the funding was invested to address those 3 groups of people I mentioned earlier. And at the end of the day, they created strategy maps that were juxtaposed to ADLI, including their outcomes. So you see the first one there for low birth weight babies. And on the second page, you see childhood asthma attacks, and you see the youth smoking. So you see those 3 strategy maps that were generated. And this is really important because these maps were rolled into return on investment reports. So let me make sure I'm keeping up with everyone. Let me do a check-in here. You should be on the 2 strategic planning maps with the anchor that say training for logic models, PDCA, ADLI, and strategy mapping.
I'm there.
And then, good. And the next one simply points to some of the processes that we measured along the way. So these process improvements to tell us we were on the right track. So we saw the youth that we were reaching out to as customers and invited them to participate on councils to give us feedback. That participation increased by 40%. The pregnant mothers who were smokers who were trying to involve in these programs to help them stop smoke doubled during this time period. So let's move on from there to the next slide for sake of time. On this slide, you'll see a 1-pager ROI wrap-up. And you can take time to digest this itself, but it tells you that the savings overall were $7,561,164. And these were, once again, measuring primary prevention, potentially averted healthcare charges. So, for example, the number of low birth weight babies born was prevented because pregnant women in their second trimester quit smoking. So they delivered a healthy baby as opposed to a low birth weight baby, which cost of delivery is much more expensive than a healthy weight baby delivery. And you'll see the other 2 areas in the red boxes, what the data was for health improvements. So on the next slide, customer focus. As I said, we use Baldrige as our primary framework for performance management. So we looked at 3 customer focus, and you'll see if you look at customer satisfaction, dissatisfaction, those scores are really high. So that tells you either we don't have enough frequency or a sensitivity of the surveys are not sensitive enough. And sure enough, at that time, we only did 1 customer satisfaction survey for 6 weeks out of the year. So because of the feedback we were getting from examiners, the Baldrige examiners from our counties, we increased the frequency That card on the right is a daily customer satisfaction card that was used in some of our health departments that decided to innovate. And the next day in stand-up, they processed all those cards before they greeted customers and clients and patients the next day. So this is important because at the same time, the individual performance plan for every employee in the state of Tennessee was now weighted at 30% on customer satisfaction metrics. So that's process 3. Process 4, moving to measurement. So on measurement, the highest levels of rewards with regards to staff were those who came up with breakthrough innovations. Those IPP results were tracked as well as those trained in and using innovation tools. And you can see the top 3 reasons folks use innovation tools at the very bottom, and that was to look at space allocation and clinic buildings to reduce service cycle time and increase dollars saved. So these were the folks who typically scored 5 on the Likert scale or received a 5% increase in their annual performance reviews. So I've already talked about the workforce, and you would think with all this happening, the workforce might hate us. But actually, workforce perceptions of rewards and risk-taking and innovation scored 10% above their national peers in believing that risk-taking and innovation was important, and 11% above the workforce compared to their national peers believed that the Tennessee Department of Health was a good place to work. Process 5, workforce innovation waves. As I said, this was a multi-phasic approach each year with new innovation waves coming each year. I won't go through every single one of these right now. If you want to talk or drill down into more of that in Q&A, we can. Operations in Baldrige is where innovation lives, and so process 6, operations. And now if you advance to the next slide, you'll see the process 6 operation innovation waves, the cascading waves of innovation for innovation as a work process. And so I've gone over most of these already. If you have any questions about those, we can drill down into those more in Q&A. So now you should see one of the state maps that we saw at the very beginning. Our performance improvement system using Lean, PDCA, rapid improvement events, basically mini Kaizen or mini Lean events, MINI events, to help make this digestible for staff and counties who want to utilize these tools. So by 2017, we had 232 of these tools used and implemented. And this isn't counting the tobacco PDCA. That was a separate study, so those numbers are not included. So these are with other health content issues and other issues in the health departments. So as I said earlier, the most popular, if you go to the next slide, the RIE reporting of 2 OPM about tools utilized and the themes of greatest frequency tracked. The most popular tools used were the 5 Whys, PDCA, and value stream mapping. You'll see there on the right, there are 9 tools that we trained in, but these 3 seem to be the most popular, although the others were used as well. The next slide, the only thing I want to mention about this is you can see the number of examiners and applicants each year utilizing Baldrige, the other map with the multicolors. And the only thing I want to mention about this is the shift that happened in 2016 to 2017 from our level 1 applicants to level 2. And those changes only come about. It's a large hurdle in the state of Tennessee because you're moving from just describing innovation to demonstrating it, to go from level 1, 2, and 3. So on the next slide, you'll see those levels defined. You'll see them broken down on the complexity and the number of questions in your application. And once again, the key difference in the hurdle between level 2 and level 3 is you have to be able to demonstrate models, and for level 4, how your models became a best practice and others used it. And currently in the state of Tennessee, no state health department has achieved a level 4. We've actually had several try for level 3 that have not made it. We have 4 out of all the counties, only 4 have made it to a level 3. So what gets measured, results of evidence, what gets done. You'll see some examples of what we measured in other important health indicators. I won't belabor that. We can answer that in Q&A. So now you should finally come to the 2012-2013 Accelerating Excellence map, which shows our first 7 innovators. And if we can just run through these maps, just let them run to the end, you'll see the diffusion of innovation. So there's 2012, 2013, 2014, 2015, 2016, 2017. So you get a flavor for the diffusion and the rate at which it happened over those years. So last but not least, here are some sample links and publications. If you go to my LinkedIn site and scroll down to publications, there are 11 more there that Mark mentioned earlier. And you can go to the tn.gov/health website for more information as well. And with that, I'll turn it back over to you, Mark.
All right. Thank you, Mickey. That was an incredible presentation. You covered such a large amount of ground there. Really much, I mean, it was very much appreciated. We did have a few questions for you. What actually drove the initiative to pursue excellence in Tennessee? I know it's rather tough in government to move the needle when it comes to performance improvement and things like that.
Yeah, so the way I would address that is, number one, through leadership. We had a committed governor with Governor Haslam and his cabinet, which included the Commissioner of Health for the state of Tennessee. One of his primary goals when he came into office was to make government more efficient and effective. And fortunately, he gave the freedom and encouraged individuals and departments to utilize Baldrige as the framework for doing that. So he's the one who planted the seed. He hired a COO who had worked for IBM, Big Blue, who is well-versed in Baldrige. And so I would have to say that was the initial impetus to get the ball rolling, was a committed governor and cabinet for discovering ways to build performance improvement and excellence systematically in departments.
Fantastic. Another question is, what things did you put in place to make the pursuit of excellence long-term or sustainable? How do you keep these things going over the long period of time?
Well, that's a very good question, because having been in state governments for a long time, at least in my perception, there are things that staff, that people really, really pay attention to. And one of those is, how am I going to be evaluated, and what might my raise look like next year? So this multi-pronged approach of tool dissemination training, but on the other hand, changing the individual performance plans to include risk and innovation, is really what galvanizes into a long-term process and commitment. Okay.
And Mickey, what are some of the obstacles that you had to overcome over the years?
Well,
did you have resistance to change and things like that?
Yes, and as a matter of fact, I was one of those resistors initially, as I mentioned earlier, because my perception back in 2011 was that these tools, all of this is just another audit. It's just another thing to bog me down. And getting around that barrier of, let's move away from compliance-based, just checking off the boxes. And then when I saw, and other staff saw, that individuals were actually making improvements that saved a lot of time and effort So we work smarter, not harder. We serve more people, and our patient satisfaction survey results were getting better. Then a county over, well, how'd you do that? You know, my results are still lousy. What are y'all doing over there? So that innovation to share and recognize really helped break down those barriers.
Great. Here's another question for you. Can you describe an example of one of your successful Kaizen events? Just to give the audience kind of a flavor for what some of these Kaizen events would be like and what it would accomplish.
So I'll pick one particular county in Tennessee, Blount County, which is on the North Carolina border. Their suicide rate was twice as high as it should be for a county population their size. So we did training on different tools, including Kaizen. And so they decided to do a quote-unquote mini Kaizen event. We gave people the freedom to do that. It was hard for folks to do a 5-day or so if they could get it down to 2 or 3 days, that was more digestible for them. So they started by bringing the community together to identify the problem and look at possible solutions for implementation. And actually, they came up with several good solutions that they could implement and make a difference about. So, for example, at that time, there are many stores that with gun vendors. And so we did educational programming and training with those gun vendors. But what we discovered was a lot of folks are on the web as a gun seller or dealer, but they're doing that out of their home. So you have no idea that a fellow in your neighborhood may be selling guns to people. So that was an aha moment that we could move upon and design mail-outs and even door-to-door attempts to communicate with these folks. And all we asked them to do, or all that was asked of them, was to give educational information every time they sold a gun, or just a flyer, a piece of educational information to go out with that gun.
Fantastic. Micky, we are out of questions and out of time. So I just wanted to thank you for doing such an incredible presentation. And I really appreciate your time and effort here. And I also wanted to thank everybody that's attending today.